Welcome everyone again to the University of New Mexico Law and Mental Health Series, weekly discussions of practice and science featuring experts in behavioral health and the law. This series is run by the Division of Forensic Behavioral Sciences of the University of New Mexico's Department of Psychiatry and Behavioral Sciences in support with the New Mexico Behavioral Health Services Division. I'm Anthony Perillo, the Forensic Psychology Training Director here at the University of New Mexico. For our talk today, if you have any questions for our presenter, enter those in the Q&A box anytime that you feel comfortable. Do know that we hold those until the end. Sometimes it's not possible for us to get to all of them, so forgive us if we don't get to yours. If you are pursuing continuing medical education credits, there will be a sign-in sheet posted in the chat box shortly. If you are pursuing APA continuing education credits, there will be a link in the chat box as well, but in the latter portions of the talk, near around 50 minutes after the hour, so keep your eye on that chat box. Make sure you bookmark the link or copy it if you're not going to open the survey before you leave the webinar, and make sure that you save a PDF version of your completed survey afterward, because we don't have access to certificates after the fact. If you missed last week's talk in the series, Dr. Terrell Taylor's helpful discussing stigma of people with criminal legal involvement and its impact on wellness is now available on our YouTube channel. The recording for this week's talk should be available on our YouTube channel later this week, and also the PowerPoint slides will be available for those that have registered for the series later in the week as well. As a heads up, next week we have Dr. Maureen Reardon, who will be discussing historical origins of our modern standards of insanity. Circling back to this week, though, I'm very excited to introduce you to today's speaker, who'll be discussing unique considerations in forensic versus other types of clinical supervision. This is Dr. Heath Hodges. Dr. Heath Hodges is a forensic psychologist currently located in Virginia. He earned his doctorate from the University of Nebraska-Lincoln, completed his internship at the U.S. Medical Center for Federal Prisoners, and completed his forensic postdoctoral fellowship from the University of Massachusetts Chan Medical School. He is board certified in forensic psychology by the American Board of Professional Psychology. He's co-developed or served in leadership positions for 3 forensic psychology postdoctoral fellowships, including as the interim director of the fellowship here at UNM, where I'll also add he was very supportive in my transition and just a pure well of knowledge in immediate and big picture forensic practice issues. He's primarily, these days, he primarily conducts forensic mental health evaluations in criminal and civil settings, and his research interests include the role of artificial intelligence in forensic practice, ethical decision-making in forensic settings, and forensic supervision practices, the focus of today's talk. So, Dr. Hodges, Heath, on behalf of your old hometown, the University of New Mexico, thank you so much for coming back and joining our series, and we're very excited and thankful for you sharing your expertise with us. I'll go ahead and turn it over to you.
Thank you, Anthony, for that gracious introduction. It's always kind of like an honor to feel like I've been part of the UNM Law and Mental Health series, and I certainly feel honored to be able to come back and present on a topic that's really near and dear to my heart. Oh, let's see, I'm going to share the PowerPoint, make sure that goes off without a hitch, and how's that looking for everybody?
We're right. We're getting close. There we go. Boom.
Yeah?
Yep.
All right. Here we are. Yeah, so I'll do some of the sort of housekeeping stuff. Anthony already did the sort of bio. I'm sure many of you are wanting to hear it again, but fortunately this will be posted on YouTube, so you'll get your opportunity then. CE stuff has been announced. I don't have any financial interests or connections to this topic, and my views are not expressed by the University of New Mexico, but who knows, if this goes well, you know, maybe that'll change. So I really want to focus on at least three points today. First, you know, I think there are some in our field who would argue that, you know, forensic supervision is not really substantively different than clinical supervision, that all of those core ingredients and mechanics are just kind of the same animal in a different setting. And I'm hoping to sort of at least question that a little bit today, and maybe prove successful in convincing you that there may be more of a difference than we have sort of previously acknowledged. There are obviously similarities between the two. And so I'm going to really kind of try to review both the similarities and then, of course, where we sort of depart from sort of clinical supervision. And sort of just rounding it out, coming full circle about, well, what are the implications? If we entertain the possibility that forensic supervision is different, then what does that mean moving forward? First, I have to acknowledge my co-authors and colleagues. The skeleton of this talk is really based in a manuscript that we had published a few months ago. And Anthony caught wind of it and was like, hey, you want to present on this? And so I got selected as sort of the guinea pig to present this to a wider audience. And so Betsy and Tally are out of Virginia. Natalie Numba is at UMass. Rick Demir is now an independent practice in Missouri, and Carol Holden's at the University of Michigan. So all solid colleagues who had a great kind of vast experiences and insights into this picture. And so I was really fortunate to be able to collaborate with them on this subject and to share it with you today. So before I can really sort of pitch anything, I think, about forensic supervision, we have to, I think, identify some common idea of what it is I mean when I say supervision. There's as many definitions of supervision as there are supervisors. And so I'm going to pull from sort of the APA's guidelines of clinical supervision and health service psychology. And there's a few sort of key components when we think of supervision, clinical supervision. It's a distinct professional practice. So it's not as simple as I'm a good clinician and then therefore I can be a good supervisor. It sort of considers its own competency, its own distinctive skill. And it's not just telling somebody what to do. It's not purely instructional. It is collaborative. It is dynamic. There is a back and forth and sort of a synergy, and you imbue wisdom upon a sort of up and coming professional and in a very organic and interactive way. You're facilitating and promoting skills that are relevant. So it's very competency based, right? You have to be competent to do X, Y, and Z, selecting testing, forensic interviewing, clinical interviewing, and you work backwards from that and refine those abilities. So you're kind of building muscle and cutting fat in that regard. And it extends over time. This is not orientation. It's not a one and done kind of thing. It starts in one place and it's very developmental. And depending on the individual and where that individual is in their training, it evolves. And arguably it eventually, sort of like a moth into a butterfly, turns into collaboration. I see that as the ultimate manifestation of supervision when it reaches its apex. Three goals really of clinical supervision, which is to enhance competence that's relevant to the kind of work that we do, ensuring that practice is informed by the current state of science. There's obviously an evaluative component to it to ensure that the supervisee is executing this stuff correctly. And this idea of gatekeeping, that the supervisor is in some ways the one who decides, are you ready to kind of go out into the wild and do this on your own? Are you going to be able to do that and adhere to the standards of practice and the process? And as I kind of go over this, be thinking, well, what's the sort of analog to forensic work? And I'll kind of explore that a little more as I go. But this definition, I think, lends itself very well to sort of forensic context as well. Supervision is not just telling people what to do, right? I mentioned it's not orientation. It's not just teaching either, right? There's more to it than that. It's not just instructional. And there's this idea, both implicitly and explicitly in our field, that supervision is not designed to sort of just, you're not just a workhorse, or you shouldn't be a workhorse. It's not just to serve the person who's training you. It's not a quid pro quo. It is a nurturing experience in order to bring up an up-and-coming colleague into the field. It's Whiplash. If you haven't seen Whiplash, it's good. So is supervision important? Absolutely. And so in the clinical literature, it's recognized as sort of a core competency. I mentioned before that it's distinct and considered sort of an ability in and of itself. And some have argued that it is the most important ingredient to producing a high quality clinician. It's intended to develop and create certain skills and to refine those and turn them from okay and good to excellent, right? Or at least competent. There's also this idea of it socializing the person into the field and this sort of acculturation of sorts. And this is also true in forensics. And I'll kind of discuss this a little bit later about how the acculturation process is in some ways a rewiring of how we're acculturated as clinicians. Um, there's this idea of understanding principles and ethics, but not superficially, right? It's not enough to just know the code of conduct. You have to value the code of conduct, and you have to be effective at translating that knowledge and those values into practice, sometimes in a pinch, right? It's very decisive and dynamic. And supervision is common. At least 40% of clinicians are doing some kind of supervision. And we know a bit about what makes supervisors and effective or ineffective at producing a competent supervisee who can do the kind of skills they're trained to do, and which practices are sort of effective. So for example, the supervisory relationship, this idea that there is a working alliance, there is trust and empathy and a common goal between a supervisor and a supervisee is been demonstrated in the research as one of the most potent ingredients and determinants of supervision being successful. And in sort of in keeping with this, the APA, as well as other organizations, have issued guidelines. The state licensing organizations, the APA, the American Board of Professional Psychology, there are guidelines and standards for how to do supervision and what things to look for. We don't see as much of that attention or that research in the realm of forensics. All right, we're going to try a Slido survey. So for those of you who have not done this, you can use your phone camera to scan the QR code, or you can type in the website and then enter the number. And this should populate in real time. So I'm gonna see if this works. If not, it's going to be a very public display of failure. Oh, see, it's looking, oh, there we are. Huh. Yeah, for the NA category, I'm envisioning people who are like, maybe some people on this call are like attorneys, for example, or they're supervisees themselves. So they're sort of not yet in a position or haven't been given the opportunity to do supervision yet. All right, so already we're seeing a large proportion. I just mentioned a stat earlier about 40% of clinicians provide supervision. We're already nearly doubling that, and so 68, 69%. And so I think that kind of underscores a bit of the relevance of this discussion. A lot of us are doing this, and so it's something we should be asking ourselves about. And arguably we're not doing that very much, or not thinking about it as a distinct sort of competency from clinical supervision. So before I talk about differences in supervision, I just have to establish differences in practice. And so it's pretty well established at this point that forensic psychology is its own distinct sort of type of specialty relative to clinical work or other disciplines within psychology. The APA is recognized for over 20 years that forensic psychology is its own division. You can get board certified specifically in forensics. And beyond that, there is this understanding, a lot of literature that just recognizes a lot of the ingredients, what we do, the principles and values and practices of forensic psychology are just different than therapeutic or clinical assessment. So I understand and appreciate the argument that maybe they are the same. So I tried to kind of think, well, what are some of the more common arguments for why forensic supervision would be similar to clinical supervision? There's undeniably overlapping foundational competencies, right? This idea of not practicing outside the scope of what you can do, of boundaries, of appropriate test selection, of consideration of individual differences in culture. All that's very similar, right? I mean, our specialty guidelines springboard off of the code of conduct and then sort of expand into the forensic realm. Arguably, the techniques are the same, right? Like modeling and Socratic questioning and insight-focused discussion. That's all going to be in forensic supervision, right? And then the supervisory relationship. And so I mentioned that earlier, that is a very potent ingredient. Is there any reason to think that that wouldn't matter in forensic psychology supervision? Yes. And so arguably, if we accept that forensic psychology and performing forensic mental health assessments itself is distinct from clinical practice, it stands to reason that supervision of those competencies may also be different. Some assumptions in clinical supervision just don't apply to forensic work. So for instance, the assumption that in clinical supervision, the priority is on the welfare of the patient. And that is a guiding principle in supervision and in the values instilled in the supervisee, has sort of already been sort of challenged as appropriate to forensic work, right? And we'll go over this a little bit later in terms of, patient welfare isn't really the target for us. The supervision techniques may be specialized or nuanced in certain ways. And so, for instance, modeling, sure, but modeling for what? And so modeling for testimony, modeling for forensic interviewing, these things may take on a different flavor if they're done in a forensic context, to the extent that it's maybe a disservice to say that they are redundant or the same in a forensic setting. The supervisory relationship I'm going to expand on, and how it might change in a forensic setting. And some of these differences as we go may seem obvious. Some of them may be subtle or a little less apparent, and some are even contested. And so I'm going to go through each of them and work backwards from that. So we all decided that maybe the best way to anchor this sort of argument was to go back to basics. And so, Halperin created this sort of seminal text many years ago that really laid out, how forensic mental health assessment is different than therapeutic assessment. And he identified these principles. And so what we decided to do was to sort of go through each of those and identify the implications of these differences in the context of forensic supervision. All right, so the first one, the purpose of therapeutic assessment is really treatment planning, symptom reduction. You're helping the patient. And forensic assessment, the purpose has been modified, right? Our goal is not necessarily to assist the individual, it's to assist the decision maker, the courts very often, on some kind of legal issue. There's a referral question that involves us in the legal system, and we are there to provide assistance for that. So, this is, I mentioned acculturation earlier, the forensic supervisor will come into play heavily here. And so this idea that clinical assessment is different than forensic assessment is not the easiest idea to get on board with, and some of those core values that we spent years in graduate school reinforcing have to in some ways be sort of reversed or rewired or sidelined. And so it's not just educating the supervisee about these differences, it's helping them sort of internalize that and make sense of it. And maybe they understand it on an academic level, but their ability to implement it, in the room with somebody that they're evaluating may not come as naturally and may require regular sort of modification. I think this idea that, and it's not a one and done thing, right? And so you are, particularly, I think, for the early on supervisee, it is a process, and it is a process that, can sometimes be challenged along the way. Maybe you're doing pretty good at being objective and understanding your kind of role, but then you have a particularly complicated case, or you evaluate somebody who you sympathize with, or maybe the opposite, and some of those sort of instinctual drift kind of comes in, and your supervisor is going to be like, whoa, whoa, wait, let's remind ourselves of these things. And they help you kind of stay on course, particularly when it's challenging to do so. And this idea of the supervisory relationship can also be modified in order to successfully implement this adjustment of what is the purpose of what we're doing. And I think that the supervisor relationship can be modified in several ways in a forensic context. This idea of support encouragement is important in both. But I think it is particularly necessary with certain kinds of forensic training. And so support encouragement, testimony is terrifying, particularly for supervisees, or it can be. And providing support and encouragement for something as pretty high stress as that can be very, very useful. And the supervisor relationship is going to come in very critically in that context. Complex cases, they're going to feel, where they might lose their way, they're not sure what to do. Support and encouragement comes in for that. And in our setting, not that this doesn't happen in clinical work, but, if they experience some kind of assault, or they're, in a facility where there's a riot, or any of these things that sometimes happen, having a supervisor there to offer that support is going to be vital in a way that just doesn't get showcased in the same way in clinical settings. Being on the same page and having mutual goals and understanding is going to be a necessary dynamic, with the recalibration process. You have to trust in them to keep you on the path. And the idea of conceptualizing cases and in how do psychological impairments translate to deficits in the psycholegal issue, you have to be on the same page as your supervisor to do that. And this requires the supervisor, of course, to have their own expertise and skills and knowledge in order to effectually do that for you. Feeling connected and having like a bond with your supervisor, in addition to managing stressful content or high profile cases. Bias, there's a lot of discussion in our field about bias and how bias can sort of compromise our objectivity. That's hard to recognize for the best of us, let alone for somebody who's kind of new to this kind of work. And a supervisor is going to be of paramount importance for kind of staying on top of that. And then, within a clinical setting, the supervisor relationship puts a lot of emphasis on, sharing sort of an empathic understanding of the patient, and the sort of underscoring the importance of the welfare of the patient. And we are changing that, right? In forensic work, it's less about client welfare and treatment. It's more about like, how do those things connect to the specific referral issue? And so making sure that the supervisor relationship funnels in that direction is also different. This is just an example of how the supervisor relationship is poor. It can be very toxic, and we don't even know how that might disrupt things, particularly in a supervisory context. And therapeutic assessment, we traditionally identify the individual in the room as the client. We assume an empathic sort of mindset and really seek to understand the world through the client's eyes. And there's a lot of importance placed on protecting confidentiality and privacy. If the court wants something from us in a treatment setting, we're sort of very protective and reluctant to give that up unless it's legit and it's necessary. It's almost reversed in some ways with forensic assessment. The client is the court. We always say that. You shift from a more purely empathic perspective, not that empathy doesn't have its place, to an impartial, objective evaluator. And those protections are very limited. Confidentiality is limited. Privilege is sometimes completely gone. And so you're going to need a supervisor to understand those nuances, and not just understand those nuances, but understand them in a way that allows you as the supervisee to describe it to the person you're evaluating. Oftentimes we do these evaluations and the individual across from us themselves is like, wait, you're a psychologist, you're supposed to be helping me, right? And so we have to sort of orient them a bit to how this is different. And so it's very important that the supervisee has a sort of an integral understanding of that. And seeing the supervisor do it effectively and navigate those questions and finesse those things is going to be very, very important. And then just, recognizing the idea that empathy and sort of this impartial evaluator thing are not mutually exclusive. It's okay to have that. You just have to know how to balance it and make sure that it's not injecting bias and doesn't, dissuade you or distract you from your role. And a supervisor is going to be helpful in helping you balance that in that transition process. The purpose, right? And so kind of dipped into this a little bit earlier, the idea that in therapeutic assessment, there's a great emphasis on confidentiality. You kind of don't move forward unless you have informed consent, at least with adults, right? And there's less discussion about the purpose because the purpose is usually fairly straightforward or mutually understood. You want to get better, you want your depression to go away, and then you just work on the plan, right? In forensic assessment, there's limited confidentiality in the sense that certain parties will be privy to that information. It's not obviously gone. And if it's a court-ordered evaluation, then you may not need consent at all, but rather you just hope for assent. And sort of understanding that nuance and that difference is its own kind of learning curve. And understanding the purpose of the assessment, what it is and what it is not, is very, very important and something that supervisees can continue to struggle with, particularly with kind of novel or uniquely forensic kind of issues. And so obviously a supervisor on some level is like, hey, here are these guidelines we have that really kind of lay out the differences of how the notification and consent process works in these settings. And again, just being able to understand that with a degree of minutia. And sometimes it's challenged, right? And so if somebody doesn't understand something, like if the court orders you to do a competency eval and an insanity eval, and they don't understand what's happening, okay, maybe you feel comfortable doing the competency eval, but are you comfortable doing the insanity eval? And so like these are the types of nuances that sometimes introduced more sophisticated questions for the supervisee that, even clinicians who are licensed don't know how to navigate without forensic training. And so having that forensic expertise is really important to sort of, figure that out. And again, seeing the supervisor actually implement these things and do them themselves, how did they describe this? How did they sort of respond to the evaluee's questions? And these things I never would have thought of before. Especially if something comes up that is sort of an exception to these things, like if there is a risk of harm issue or a terrorist issue. In a forensic context, sometimes those questions are just more complicated or nuanced than they might be in a clinical setting. And so a supervisor is going to help them figure out how to navigate that stuff. Doing it is also important, obviously, but like knowing how to write it up, knowing how to describe it, knowing how to sort of address those nuances. You say they understood the notification of purpose. How do you know? And so, well, there's a way of describing that, right? This is a big one it comes up a lot when we kind of talk about the differences between clinical and forensic work. This idea that who we are serving and who is our duty owed to, and what do we do with this idea of client welfare in a forensic setting? Because for us, we're kind of informing, we're almost consultants in the sort of casual sense of the word to the court. And we do have a duty, but it's really owed to who hired us. And, there could be an argument that we're sort of serving a social welfare sort of agenda because the decisions that we make don't always benefit the person that we're evaluating. And that can seem very antithetical to a clinician. We've been wired that we don't do things that patients don't want or that they perceive as harmful to them. But that's not always the case in forensic work. If I'm asked to do a risk assessment for purposes of informing involuntary hospitalization, my decision may very well, through their perspective, not be in their best interest. And so you're going to have to help the supervisee understand, like, well, where do we pull that information from? How do we even read certain statutes and guidelines and understand these system expectations? Part of it is almost like a politics thing. There's a lot of players and stakeholders, whether you're working in a hospital setting or administration or sometimes private practice. And how do you navigate all of these different people wanting different information from you? And this idea of cultural responsivity, and that you still have some fiduciary duty to the person that you're evaluating, and you still have some duty to do right by them by sort of characterizing their experience in a way that is accurate as it applies to the referral question, and selecting tests that are relevant and things like that. And so a supervisor is really going to help you kind of keep your finger on the pulse in that regard. This is also where a lot of bias can kind of come into play, and your own worldviews and your own experiences and maybe your own kind of identity. And having a supervisor that you trust, that you can talk to about these things, is going to help you as a supervisee arguably make sense of that, especially with what we know about bias, and that having like a third party kind of check us is sometimes the most effective way of sort of identifying those things. In this kind of work, we are introduced to so many populations that are disproportionately represented, and being mindful of that as we do this kind of work is not just important, it serves sort of a greater purpose in terms of making sure we're not sort of feeding into the machinery the problem of these injustices, and how do we monitor that and make sure that we're on the sort of right side of it, and how do we write it up in a way that is just as sensitive and delicate. I'm going to do one more of these, and then I'm going to have another survey thing, because I know it's a lot to kind of talk about each of these like in a dry manner. And then, of course, the standards, like how do we do this well? And clinical work, it's pretty, I think, linear in a way. Like there's standards of practice that are in our code of conduct and professional ethics. And yeah, there's some laws out there about like mandated reporting, but otherwise that's it, right? And so in forensic assessment, there could be a lot of other sort of standards that we have to explore, and they are not often handed to us. And sometimes the attorneys or even the courts don't really know what they are, or at least not on a level that would be helpful to us. And so we have to kind of investigate a little further. Okay, so what is the standard on battered woman syndrome in Ohio or whatever? And so kind of helping the supervisee learn how to research that stuff, knowing how to interpret it and how to deconstruct it and identify the sort of psychological functioning equivalent to inform it is a very sophisticated process, and one that certainly would require, especially in the beginning, supervisor sort of instruction and guidance, and sort of helping them understand. Again, it's a bit of a like the legal system's worldview is its own sort of thing to adapt to, and how do you reconcile some of those competing interests? And so I know a big talking point in the field right now is this idea of, the courts or attorneys sort of demanding test materials for evaluations that we've conducted. And there are members in the community, particularly the neuroscience or neuropsych community, who are like, we don't do that. That conflicts with our ethical guidelines. And then there are those on the other camp who will say, well, no, there is a way to reconcile this. You just make certain concerns clear, and then you do what you can to protect against certain leaks, protective orders, whatever. But that kind of discussion requires the individual to have a very informed and nuanced understanding of the issues at play and the values that are being challenged, and then to sort of implement them effectively. And then, of course, forensic conceptualization gets kind of brought into a lot of this as well. And I kind of mentioned that a bit earlier. All right, so this is really me just trying to break this up so I'm not just spinning through all of this ad nauseum. But I'm curious, although I'm like halfway through the pitch here. Well, look at that. Well, that doesn't look good for me at all, does it? I'm hoping more people vote on this. Oh, that's right. Reverse the questions. That was actually good for me. Okay. Are they the same? Important differences, mostly the same. Wow. I'm actually a bit surprised by this. In a good way, I guess, from my perspective. Like, I actually thought more people would either be on the fence or like, no, they're the same. And obviously, this is not like a national, well, it is a national poll, but the idea that there may be quite a few people that see it as different, and yet there is so little out there that says they're different or that gives instruction about, well, how do we transition from supervision in clinical settings to supervision in forensic settings? How do we even do, let alone to transition forensic supervision? This sort of underscores the importance of maybe having that dialogue. All right, so between 85 and 90% say there are important differences. Okay, I like these Slido polls. I think that this one is one of the most compelling reasons for why it's different. And so, in clinical work, in some ways, there is a lot of reliance on self-report. That's not to say collateral information or records don't come into play, but it doesn't have the same gravitas, right? It's considered acceptable if you sort of, because you're seeking to see the world through the lens of another's eyes. And so, and then if you do testing, it's to explore better understand an issue that they're reporting. It's to clarify your differential diagnosis. And forensics, like it's pretty exceptional if you only rely on one source of information. You sort of open yourself to a degree of challenge and scrutiny if you don't. And that's not to say you can't, but it's emphasized as sort of the standard of practice, right? And testing can be done for many different reasons, because the emphasis is not necessarily on diagnosis, but the psycholegal question. Testing is supposed to directly inform that in one way or another. Oftentimes, it may be to corroborate or dispute an alternative hypothesis. So malingering is a classic example, or to just kind of clarify the nature of the deficit and clarify the nexus, like how that connects to the forensic issue at hand. And so in supervision, there's really this idea of Socratic questioning, like, are you sure? Like, why would you want to call that person? Well, why would you need this record? It's our impulse sometimes to say like, oh, all of it. And I don't know that that is necessarily justified, right? And so if somebody is 19 years old and they're doing a competency evaluation, but the basis of everyone's concerns and from your observations after the interview is that it's related to, say, psychosis, do you need school records? Well, maybe not, Yeah, sure, you could talk to mom, or would it be more useful to talk to a teacher? Or if you're doing an insanity evaluation, maybe somebody who's there, And so there's all these nuances, and it's every decision for a third party or collateral source of information is very deliberate. It's not merely as binary as more is better. And then when do you stop? You get those questions on the stand all the time. Well, did you get this information? Why not? And so really exploring why you would pursue certain kinds of information, how you get those information, how you summarize them, to what extent you summarize them, what do you say if you don't get them, and then like even practical issues like, well, how do you conduct a collateral interview? How do you craft those questions? What do you do if mom starts crying on the phone with you and ask how her baby's doing in jail because nobody will talk to her? Yeah. So, these are the challenges that you might not think of that a supervisor could really kind of help fortify. And of course, that the test selection question, that it's never a battery that you always give to everybody. It's always, again, very deliberate. And then, of course, what do you do with competing data? And that is, I think, in some ways where the supervisor can be most critical, because that's a level of critical thinking that we don't often get sort of taxed with in clinical work. We don't always have to find the truth, right? To us, as clinicians, sometimes the truth is irrelevant. What matters is how the client sees the world or what the client thinks happened. And of course, response style, which is in some ways an offshoot of that. But in therapeutic assessment, we assume the person's being honest. If there's some misrepresentation or problems with consistency, we don't sort of assume the worst, but maybe it's internally motivated. It's denial, it's defensiveness. They're just not there yet. In forensic assessment, we're really taught to just first and foremost always question the presentation and someone's response style. We don't always go down, the path of, malingering and assessing for these things, but we always consider it because authenticity is not a given and effort is not a given. You don't give an IQ test without some kind of measure of effort or, something like a VIP or whatever. I mean, you can, but, it's not, typically something we do. Because we always have to address, like, well, how do you know they weren't trying to present themselves as less intelligent than they are? And malingering, just in terms of base rate, is just frankly more common in forensic settings because there is often some pretty obvious type of secondary gain, whether it's to, win a lawsuit or be transferred out of facility or, to not go to prison for their whole life. So this is going to require not just education, like here's what malingering is, but here's what malingering isn't. There's a lot of myths out there, that whether, they're obviously BSing me about psychosis, so there's no way they have intellectual deficits, or they malingered in the past, they must be malingering now. And how to or it seems like they're malingering psychosis, so they don't actually have psychosis at all and never have. And then just sort of calibrating this sort of temperament to be sort of skeptical, but not cynical, to not just dismiss somebody as a malingerer because certain kind of flags go off. And how do you let the data guide your decision making? Malingering cases in particular, they're really a process from like, when do you start to identify flags to how do you assess them in the moment and during it, and how do you make sense of them afterwards? And how do you transparently and effectively communicate sometimes like complex data in a report to layman's? And the supervisor is going to be the one that says, well, how do you know it's not this? Well, isn't it possible that this could be the case? And for it to be sort of a constructive process of, what's the alternative hypothesis? Did you consider that? Did you let the reader know you considered that? And so on and so forth. So in clinical assessment, correctness is assumed, right? You don't have to justify each and every little point you make, right? And so if you say that the client was agitated, it's usually all you have to say. And if you get challenges, it's in the context of, well, I'm not sure what you mean, or we're all trying, we all have the same goal here. That is not a given in forensic work, right? And so you expect to have your findings scrutinized. And because of that, you are taught to fortify everything you say with data or explicit rationale. And if challenges come up, they're not always pleasant. And so there's a bit of sort of training from the supervisor to be like, you really need to unpackage what you mean when you say this, or how do you know it was agitation and not test fatigue or whatever, and sort of challenge the reasoning through that. And this is another example where the supervisor has an opportunity to sort of model and show their reports to the supervisee, like, you saw this person with me. Remember how we talked about how tricky that was to explain? This is how I did that. And how, you can be transparent if there are limitations. Limitations is something we don't often have to discuss in clinical context. And for some supervisees, there's going to be resistance to that. They can personalize it. It can feel like it's undermining their opinion. And that's not always the case. And we always kind of have to show our limitations. Obviously, in clinical work, typically you have like SOAP notes or something, right? If you write a report, you expect the reader to be a clinician. We write pretty extensive and detailed reports. Some of us write really long reports and really extensive reports. And we expect them to be read by people who are not psychologists like us. You're going to have to basically teach your supervisee how to write differently and how to read. And, they're not trying to impress anybody in academia with how smart they are or their advisor with how much they understand a client. They're trying to explain to somebody who's not a psychologist why these things do or don't apply to the issue they care about. And that every opinion they give is sort of justified in the text. If you read a conclusion and it mentions something, you're like, well, there's no data up above to justify this. They have to reconcile that. A lot of anxiety from supervisees. I'm submitting this to a judge in court. I could be asked to testify. Everything is scrutinized. How do you help them digest that and make sense of it and just get better at it? And you as a supervisor have to like kind of read the reports with a fine tooth comb in order to catch those things so they don't learn the hard way and sort of help them catch their mistakes and get better at it. And then lastly, testimony. So in clinical context, obviously testimony is something that rarely happens. If it does, it might be more as like sort of a fact witness. It's sort of very novel and unique to have to develop a communication style in a courtroom setting for a clinician. For us, testimony is certainly possible, even for supervisees at various levels, and preparation of testimony, even if it doesn't happen, because you get called and it doesn't go through, is vital in figuring out how to do that and how to communicate to the court. So these are in some ways very sort of, there's not a lot of analog skills to this in clinical settings. And so really supervision comes in a pinch here. What is the courtroom setting like? What's the adversarial process like? How do you respond when an attorney says X, Y, and Z? Brodsky's written so much about this. And that in some ways produces a lot of anxiety because we talk this up so much. Supervisees are like, when they come up to it. And so that's really where seeing supervisors testify, the mock trials, those types of things are going to be really clutch to help finesse this. And I think make forensic supervision very distinctive in that way. And not just like support and you can do this and here's what you need to focus on for this evaluation if you're going to testify, but also like that sort of post-testimony process and encouraging the supervisee. How did they did? What could they have done better? Don't beat yourself up about this. This is an area to grow on, so on and so forth. All right, so I'm rounding it out with another poll before we get to the Q&A. I got like one slide after this. So I'm just curious, like differences recognized or not, like do we need specific guidelines like we kind of do with the specialty guidelines or like we do with telehealth on forensic supervision? Like would that be valuable? Wow. That's cool. It seems like overwhelming support, 90%. It's interesting. The percentage is actually higher than the percentage of people that think that forensic and clinical supervision are distinct, and clinical supervision has guidelines. So, yeah, all right. Oh, neat. Uh-oh, spoke too soon. All right. So, some takeaways. And yes, that's a unicorn. I don't know if anyone caught it, but there was literally a horse of a different color on all of those slides. So, in general, clinical and forensic supervision obviously overlap in several important ways. One of those ways being that just because you can do doesn't mean you can supervise. And that's an important thing to recognize. And it's something we haven't really addressed in our field. And hopefully I made a compelling argument for why it's unique. And so, again, this idea that if we accept that there are different principles, that suggests there should be different supervision practices. recognizing that just because forensic work is so specialized, that supervisors themselves should have a certain set of specialized skills specific to forensics. Um, and just this idea that novel settings and the types of things that we do, even if they are similar ingredients, it may modify them, including the supervisory relationship, in critical ways, to the extent that it's no longer really the same. So where do we go from here? I think the first thing we do is start thinking about it. Looking at supervision practice and being like, well, how is this different in forensics, and what should we be sort of really emphasizing? And I think it's really, really important to get this information from the supervisees, the ones who are having to go through this transition or having to refocus their careers, and how do they perceive the differences? Consulting with colleagues and people who have been doing this kind of supervision and forensic work for a long time, and seeing what kind of nuggets of wisdom they have to offer. I think that whether you're part of like a group practice or a state facility or academia, training center, that there should be some kind of formal guidelines for the expectations of supervision and some mechanism for evaluating the effectiveness of supervision. Maybe someday we'll elevate to the level of guidelines, but if not, like for instance, the specialty guidelines are being revised, I'd like to see a lot more, just more than just like, yeah, you can respecialize with supervision in the specialty guidelines, that gives some attention or at least recognition to this as its own thing, that at least something we should pay attention to because it's important. And then of course, more theory, more research, more trainings. Is that it? Oh, yep, that, and then, okay.
All right. Well, thank you so much, Dr. Hodges, Heath. It could be my familiarity with you and hidden Easter eggs, but I caught on to the horse of a different color very quickly. And so I hope people got a little kick out of that. And then thanks for the helpful overview. I'm curious of how some of these end surveys might have been at the beginning of the talk. I think
I had the same thought, dude. Yeah.
Yeah, I do think that they could be a reflection of, how clear and compelling some of this was about the considerations of some unique aspects between forensic supervision and what we've been traditionally trained to do in clinical work in terms of how we supervise trainees. So we do have a couple of questions here already in the Q&A box. You can feel free to address any other questions here as well in the Q&A box. We'll do what we can here. In the meantime, the CEU surveys are available. There's the QR code. Go ahead and check the chat box as well for other links to the survey and all that. Zooming out a little bit, because someone asked, as you were discussing some differences here, just even going beyond supervision, they said profound differences between clinical and forensic work makes me wonder whether in the long term being a clinical psychologist is actually the best background for forensic work. There's an awful lot of unlearning and de-emphasizing, it sounds like, of one's clinical training required. One might almost say the only thing forensic and clinical psychology have in common is the fact that mental health issues are involved. What are your thoughts about this continuum here about importance of differences in supervision versus should forensic psychologists be trained as forensic psychologists? Is there critical differences between clinical and forensic work?
Yeah, well, I guess I think first you have to recognize that, as basic as it sounds, understanding, mental illness and all of those other things is no light task itself. I mean, clinical psychologists go to school for years to do it. I don't think that you just only need to be a clinical psychologist in order to segue into forensic work, like counseling psychology. I know the really good forensic psychologists who've done counseling programs. I mean, sure. I think how cool would it be like if we could have like a forensic psychology program that would somehow still be, credentialed and qualified, that had this sort of perfect hybrid, right? So that we wouldn't have to retrain. And I think John Jay, it seems like kind of tried to do that in the beginning before they're like too much red tape. We got to do the clinical with forensic emphasis. So I mean, I think it's a cool idea if we just had a forensic specific thing. It's also like I think it's challenged by the idea that forensic psych is not exactly a homogenous sort of practice itself, and so that might make sense if you were just doing adult criminal work. But then what if you want to do civil work, or what if you want to do disability? And so like I think different clinical skills get tapped and taxed and modified depending on the type of forensic work you're doing, as well as the type of clinical training you had. So hopefully that was a sufficiently complicated answer for a pretty sophisticated question.
Yeah, thank you for that. What are some helpful strategies you recommend to those who are new to forensic supervision, particularly to provide effective feedback on forensic report writing?
On forensic report writing. Yeah, so um, it's hard in a way to know exactly where the question's coming from, but and I get it. It's like it's hard to know what you don't know, kind of thing. Um, but I think first I think a conversation with your supervisor about like what do you think is the difference between clinical and forensic writing, and getting a sense of that. There is some literature out there. Demir does some of it, Tom Driscoll's done some of it, that talk about nuances in the writing and how it's different. And so I think that would be a good sort of starting point. And then as the person starts to write and they figure out their own sort of challenges, whether it's the use of psycho jargon or jumping to conclusions or not ruling out alternative hypotheses, then you can sort of individualize that and get more sort of specific feedback. And of course, insight about like why is this a challenge for me? What am I struggling with? What's not clicking? Helps. And then templates, like if you think, oh, I'm not really sure how to write up somebody who's malingering but has also genuine deficits. If the supervisor has examples of that you can kind of get inspiration from, I think that's also can be helpful.
Any particular considerations about cultural assessment in forensic work specifically?
You say ultra assessment?
Cultural.
Oh, I was like, what is it? Like transfer? So they just want to know specific thoughts about cultural assessment and forensics?
What about inclusion of cultural assessment in forensic work? Are there any differences that you've seen in cultural considerations, cultural assessment in forensic work that goes beyond what we do in
Oh
clinical
yeah, I mean
supervision?
that is such a huge conversation to have. Yes, everything from test selection and appropriateness and interpreting that. I mean, the testing thing is its own animal. To depending on the referral question, like if it's competency, can culture be the basis of an incompetency finding, or is culture just informing the way that they see the legal system in a way that doesn't make them incompetent. It can create all sorts of considerations for understanding someone's background and experiences for mitigation. If you're doing, personal injury, then that can, of course, inform, how they're responding to whatever the sort of legally relevant event slash alleged trauma is. I think it's relevant in almost every facet that I can think of, depending on the individual as well as the issue. And so, geez, all right, I don't even know how to give like a sort of succinct answer to that. So,
Yeah, no, your
yeah.
first response jumped out to me as though, yeah, a lot of times in clinical supervision, we take a lot of cultural data and then try to fit it into a cultural context. And your first response there is zooming out, where a lot of times you have to tell people when we consider cultural assessment why we even did something in the first place, why we administered a test, why we asked a question, why we're justified in doing anything we do, let alone our interpretations of the info.
Yeah. To say nothing
Yeah.
of culture in supervision itself between
Mhm.
supervisee and supervisor.
Absolutely. Um, it, Somebody asked early on, you did get into content differences between supervision and clinical and forensic work. Their extra point is, are there any particular style differences? I'm assuming more like dynamic between supervisee and supervisor. It says, what style differences are there between supervision and consultation and clinical versus forensic work?
Well, empirically, we don't know. I think some people might say that we're sort of more, I don't know, there's more dark humor or sarcasm, or some would say there's a colder dynamic there. Um, there's some research I know about the supervisor relationship, and I can say at least it's just as important. I don't know if the permutations of style and flavor beyond just sort of individual differences would be different. I think that's a really cool question, though. It's a
Yeah.
really cool question.
And since we are at the top of the hour, just one person asked near at the end if you could clarify. They were wondering if there were two Gandalfs or something earlier in the presentation, and said like what they were, no big deal. They were just wondering about the meaning.
Two Gandalf. Oh, no, no, those were not Gandalfs. That was Dumbledore. And I have a lot of strong feelings about this. There are two actors who played Dumbledore in the Harry Potter movies. Richard Harris was in the first two, then he passed away, and they had to replace him with that other guy. And so I put it in there as kind of a joke of effective, ineffective supervisors, because of my personal preference of effective and ineffective actors playing mentors, supervisors, and the role of Albus Dumbledore.
Well, there you go. Thank you so much, Dr. Hodges Heath, for all the considerations and the work you do in this area, and then your willingness to share all of this for us so that we can all be better supervisors and also just do better forensic work. And best of luck as you continue to do all of this work, and good to see you as always.
Thanks, man. You too.
All right. And that wraps up this week's Law and Mental Health series. Next week, we have Dr. Maureen Reardon, who will be discussing historical origins of our modern standards of insanity. We hope to see you then for another great discussion of issues in behavioral health and the law. Until next time.